I keep telling people, flattery doesn't work, right? Never, ever seems to work. It's nice to see some old faces here today. Really lovely. I only live down the road in Tottenham. Not quite in Enfield, I'm very sorry. Maybe one day. But yeah, my name is Andrew. I am the Autism lead for the London region with NHS England, which is not as crammed as it sounds. They didn't use the microphone. Oh, right. Okay. So I do need the microphone. Okay. So yes, I am the autism lead for the London region of NHS England, which, as I say, is not as grand as it sounds. And whilst I don't want to bore you with NHS governance, no doubt we'll have to touch on that a little bit as we go through. But here I am, and I think, like Nanny was saying, I am also autistic. Although, like a lot of people, I didn't know that till later in life. In fact, I got my diagnosis, identification. I think language matters, and we'll talk about that today as well. But I got my identification diagnosis 11 years ago at the age of 40. That's the point where you're most supposed to shout out, surely not, Andrew, you can't possibly be. Dear, this talk is going very badly already. But sorry. And what we're seeing is an increasing number of people being recognized as autistic later in life. Particularly parents watching their children go through an autism assessment process. And as they're watching their kids go through that, pennies are dropping for them. Oh, but that's, And realizing that they themselves have been autistic all along as well. And I'm not saying anything controversial here today that I still don't understand, and neither do many of my colleagues, why we still publish a national prevalence of autism at around 1 or 1.1% of the population. Nobody thinks that's true anymore. In fact, based on the latest research, really big studies, 120,000 English school kids, for example, we're looking at approximately 1 in 35 people likely to be autistic. That is 3 to 4 times as many as we publish. Those figures, of course, are skewed by the under-recognition of older people who missed their diagnosis earlier in life and various other factors. And that figure is mirrored in America as well. They quote 1 in 36. So I feel fairly confident in saying that. But that means that there are a lot more of us out there than society currently recognizes. And we're not just patients or social work care clients. We are also parents, colleagues, friends, partners, husbands, wives, carers, and all of those things as well. It shouldn't be remarkable that an autistic person has the job that I have. I suppose a relatively senior job about autism. It shouldn't be remarkable that over half of my team is also autistic. But it is. I'm very sorry to say that it still is. And I think a lot of what I'm going to say today is going to be about changing the narrative. I hope you'll understand why at the end of it I think that is so important to changing access to healthcare and inclusion in and of itself. We'll certainly touch a bit on that. But I think it starts with changing our understanding and changing that narrative. It shouldn't be remarkable that I have the job I have. But for far too long, the narrative and conversation about autism has been led by non-autistic people. I'm sure people from other minority groups recognize similar experiences. And whilst I think, I never for a moment suggest things are fine or perfect, but I think at least there would be a finger of complaint in the air if conferences on sexism, gender issues only had male speakers, if conferences on racism only had white speakers. People would be quite rightly complaining hugely about that. there isn't even a finger of complaint in the air that the conversation on autism is still largely led by non-autistic people. And I think that fact in and of itself, again, remains at the heart of why we have so many problems and misunderstandings about autism. And we need to change that. I also kind of subtitle anytime I talk about autism as the more we learn, the less we know. I think we are very much in a state of change and flux. There is almost a tsunami of research coming out, one of which I've quoted already, some of that quite game-changing in terms of statistics and understanding. Yesterday I did some training for Brent Council and started with the same quote. And I always, when I do actual training, lay two bets with my trainees. The first is that if they'd done any autism training before, even a couple of years ago, they'd probably have heard different things to what I said yesterday because of that game-changing research. And who knows what I'll be banging on about in 2 years' time myself. I think we're likely to see even more new research, statistics and understanding. Things like hypermobility being linked to autism, for example. But the other bet, to go back to what I was saying earlier, that I always lay, is that if they had done that training before, it almost certainly wasn't delivered by an autistic trainer. And again, that fact remains at the heart of why I think we still have so many problems and misunderstandings, and why organizations like this, bringing autistic people together, is so important. So I think language really does matter. I think it drip feeds a message down to the wider society, indeed even to ourselves in our own community. I know we don't all agree on how we'd like to talk about ourselves, but we do know from surveys and conversations that around 85 or 90% of us prefer the identity-first language, as do I. I introduced myself by saying I am autistic. I am autistic because that's who I am. There's no non-autistic Andrew inside me struggling to get out. I'm not trapped inside some shell. If I wasn't autistic, I wouldn't be Andrew. I would be somebody else. And despite what my mother thinks, I am relatively happy being Andrew. But that's a whole other story and years of therapy. Don't get me started. But I think that is so important, isn't it? And you may or may not be surprised to learn that even with the job I've got and the meetings I go to, how often non-autistic people will talk about me not using my preferred language, not using the ways I've referred to myself. And I often wonder at what point we're allowed to get angry about that. At what point does the education piece end? We've asked very nicely for a while now, folks. And are we allowed to start saying, no, it's not okay? Because that's about trust, isn't it? That's about trusting the healthcare or social care professional in front of you, that they know the basics of this stuff, that they've done their research, that they know what they're talking about. And we know, unfortunately, that trust is rather lacking for us as a community when accessing lots of those services, because it ain't gone so well far too often. In fact, we know some really disturbing statistics. We know that around 77% of us, that's over 3/4, won't even go to the GP when we know we need to go to the GP, because it feels too traumatic to get through that process of making a phone call, because there's no other option than a phone call. And I might not be feeling particularly chatty today. Phones might not be my thing. And then I'm given an appointment in a noisy, busy waiting room where there might be horrendous outside noise, or indeed inside noise, screaming kid. There might be one of those relaxing, notice the finger waggling, TVs in the background or radios that apparently relaxes neurotypicals, but it's just another input that we have to deal with, just another thing to stress us out. And that all means that we don't go. That feels more painful and more traumatic than the thing we've got that we were going for in the first place. It is no surprise that we only meet autistic people in crisis, when we really, really need some help. And it shouldn't be that way. There is so much that can be done, and really at zero cost, most of it, to make things more accessible. And it wouldn't just help autistic people. Putting a photograph of a front door of the place we're visiting costs nothing and would help lots of people. Those living with dementia, for example, would benefit from things like that as well. Putting a photograph of the person you're seeing on the letter or email would cost nothing. I understand that sometimes people run late, so do I. That's okay, but just let me know. Proactively offering to come and get me from the waiting room so that I can wear my headphones, that I don't feel too anxious to take them out in case I miss my name being called, costs nothing and would make yet such a big difference. And of course they have to believe us, right? The stuff they can't see too often goes unbelieved. But getting those things right, getting the environment right, is as important for us as a wheelchair ramp is for a wheelchair user. It makes all the difference. Too often we are counted as did not attend. We did attend, we got as far as the front door. We just couldn't bring ourselves to go in because it was echoey, noisy, busy. I know a multi-millionaire, owns his own helicopter, South African, done amazing charity work, met Nelson Mandela. Here was a man who told me that he left his house 4 hours early for his autism assessment appointment because he was so anxious about finding the right building, because they hadn't put a photograph on the letter. Multi-millionaire. So to go back to my thing about language, this is why for me it's so important that we also scratch that nonsense about the spectrum being linear, about mild autism, severe autism, if you'll forgive me swearing, high-functioning autism. I'm so sorry to swear in front of you. But why those phrases to me are meaningless and so unhelpful, and why again they drip feed the wrong kind of message. I'm so disappointed that I still see high functioning on clinical notes and things like that. It's never been a diagnosis, of course, just something people banded around. Look at my friend there from South Africa. Look at Dr. Ros Blackburn, who lectures on her own autism, and I'll use her own words if I may. Dr. Ros Blackburn, PhD, who says she wears adult nappies, her language, because she doesn't remember when to use the toilet. What is high functioning? PhD, really doesn't help us, does it? So I think we've made two fundamental mistakes with language. And I'm so sorry, I have to give that trigger warning now. Genuinely, folks, I am going to talk about suicide and things like that. If you need to leave, this is your chance. Absolutely would be fine with me, but I do need to say that out loud. But we've made two fundamental mistakes. We've looked at people who are both autistic and have a learning disability, and we've called them severely autistic. Huh? That's like measuring an apple by a pear. Two things that have co-occurred, but should not be measuring each other. That's like saying someone who has cancer and diabetes must therefore be severely diabetic. No, they've got two things going on, sure, but they don't measure each other. And then, worse than that, I think for far too long, we've been using the wrong yardstick to measure a happy, successful autistic life by. And again, I would never want to speak for anyone else, but speaking with lots of other people, I'm sure other minority groups have felt and expressed very similar feelings to me over the years. Being measured up against something we are fundamentally not And what message does that drip feed down to us? You're not quite there yet. That you're a bit broken. Oh dear. And the closer we've got to looking like we do measure up against that neurotypical measure of success, people have congratulated us. Well done. Well done, Andrew. You're nearly there. Look, you've got a job. Woo! Who knew? You were married? No. Genuinely, folks, I have heard in the last 2 years, GPs refusing to refer someone for an assessment because they were married. Apparently, we're not allowed to do that. We're incapable of that because they had a job. We all know the old chestnut about eye contact. And why, again, the language has to change for me, because it starts with. But we've been asked and congratulated. We've been called mild and high-functioning. And what's implicit in that language is, therefore, you don't need any help. Well, sometimes we do. I might not need it for months or years at a time. For me, the 3 fundamental principles of support for us is that it should be lifelong, specialist, and drop-in, drop-out. That's what it boils down to for me, and based on consultations and just conversations with many other autistic people. But here's the real kicker, and where those trigger warnings start to kick in, folks. What we know is that autistic people without a co-occurring learning disability are pretty much top of the tree for dying by suicide. We are 9 times more likely to take our own lives than anyone else. The only other group that might be up there with us are the trans communities. The data set on that, whilst anecdotally I'm sure is true, is not quite definitive enough for me to say that out loud, but we know it's true. But we know also from research that if you are trans, you are 3 to 6 times more likely to be autistic in the first place. You'll see on later slides, if I have the time to get there, that we have commissioned from my team an online resource for trans people who are also autistic, coming soon, I hope. 9 times more likely to take her own life. My first attempt was at 14. I'm very open about these things. I think I have to be. Of course, I didn't know I was autistic then, neither did the psychiatrist in front of me. I was put on Valium, so, there was an upside. But spent 18 months in total silence in front of that psychiatrist, because she wouldn't start a conversation, part of her methodology, and I didn't know how to. And again, like I was saying with our visits to GPs, the trauma of sitting there in that silence, did nothing for my feelings. I think almost my first words 18 months later were, I think I want this to end now. It shouldn't be like that, and it doesn't have to be like that. We know that 7.5% of all men and 15% of all women who end up in A&E after a suicide attempt are autistic. We know we die earlier than we should because of epilepsy and suicide. We know from research based in a coroner's court that just under 11% of suicides are autistic people, not all diagnosed. And anecdotally, because data is still poor, based on the problems with diagnosis, where that happens, how quickly that happens, and how that happens. But we estimate that at any given time, somewhere between 15 and 25% of our mental health inpatients are autistic, although around only 10% are formally diagnosed. And we know that we need different therapeutic input that takes into account our environmental needs, but also things like alexithymia. I'll come on to that in a minute, but just as a quick show of hands, who in this room has heard of alexithymia? Not as many as I thought, but I get a similar minority even when I talk to psychologists and psychiatrists, and yet it is so fundamental to understanding autism. I will come on to that in a minute. I promise I won't leave you hanging. But it's so important then to change the yardstick. It's not about treating or curing. I find myself using this phrase more and more often, that perhaps we should be talking about autism with the language of minority and a lot less with the language of pathology. I think that would be a great start. It is no surprise you only meet us in crisis. It is no surprise we only get diagnosed when we're struggling. After all, the diagnostic criteria as it stands today depends on you having a problem, right? If you're a happy, successful autistic, you probably don't meet the criteria for diagnosis as it stands. What a strange place to be. What a strange place to be. And yet, as I say, so much of that could change so easily and so quickly. I will, just before I move on then, talk a little bit about that alexithymia. It comes from the Greek, alexithymia, no vocabulary for emotions. It is a standalone diagnosis, and around 8% of neurotypicals would get that diagnosis. It's not just an autistic thing. The most up-to-date research suggests that around half of autistic people would also be alexithymic. And of course, the stereotype of alexithymia is that we look at someone else, we don't read their emotions very well, and then we say something they think is rude, right? We've all come across this. But the key thing for me when I got my own identification was understanding alexithymia for myself, that I didn't always understand how I felt. My body did. Again, we know from research that the neurotypical part of the brain, this is new research, so again, not quite definitive, but the neurotypical emotional part of the brain lights up more strongly than the neurodivergent. But in contrast, the physical reactions to emotion are much stronger for us as neurodivergents and neurotypicals. So we know what we're feeling, we just haven't quite clocked it in the same way or as early as others. It's why, again, that therapeutic approach needs to change, to be more understanding, to be more specialist, to help people learn, as I've had to do, that, oh, my hand is shaking. Oh, I've learned that probably means I'm worried about something. Been to the toilet 4 times in half an hour. I wonder what's going on. And I can look around me and see what's happening before I'm at the cliff edge when even I know what I'm feeling and I'm in danger of meltdown or shutdown. But think about that in terms of the whole therapeutic approach across both healthcare and social care. How many questions do people ask that start with, how do you feel? I don't know. And of course, I want to give an answer. I don't want to look stupid. But the answer I give might be fairly meaningless. So we need people to understand, to change their language, to make things more concrete, to scrap that, what's your pain level on a scale of 1 to 10? Huh? Is a broken arm, how do you give a numerical value to pain? What? But we can change that. We can make things more concrete. Does it hurt more or less than when you stubbed your toe? Oh, okay, now I've got that. I can compare that. Does it hurt more or less than last time you were here? Just change the way questions are asked and rebuild that trust in the system. So what are we doing? Again, I won't bore you with it hugely, but the role of NHS England is different to what it was a couple of years ago. Your local health body, known as an ICS or ICB, Integrated Care System, Integrated Care Board, has become independent, and roles of teams like mine are not the same as they used to. But we do run a community of practice across London every month, run by my co-production manager, Carly Jones. Some of you may have heard of Carly. She's quite big in the autistic community. We're towards the end now of an Autism in Schools program, which for the first time has taken a whole school approach, not just putting the onus on the autistic child to change, but on everyone to understand each other, to genuinely meet in the middle, to learn to speak autistic as much as we have to learn to speak neurotypical all the time. That double empathy problem you might have heard of, where it is as hard for us to understand them as it is for them to understand us. But that's not just our problem. We've done some work on support planning. We have genuinely saved lives with that. I won't go into detail for confidentiality reasons. But giving people the proper time to do some life planning and support planning, and Advocacy Plus, where we have helped to train healthcare and social care staff in legal literacy. Because again, I'm afraid to say sometimes people in good faith will say in meetings things that aren't entirely legal for them to say. Oh, we cap our care costs. Oh, no, you don't. You might do, but don't say it. Revealing what's actually going on behind the scenes sometimes, and too often. We've produced a feeding and eating disorder toolkit with a clinical fellow, co-produced entirely, which we are just at the end of piloting, because again, we know that those things too often overlap with our communities. And we had some personal health budgets, one-offs, to help people get out of hospital more quickly than they might otherwise have done. My new world, where I have a lot less budget, I'm afraid, looks a bit more like this. We're working on a toolkit with Nick Chown, who you may know from his various bits of research, did with Dr. Luke Beardman quite a lot. He's producing a toolkit for autistic adults who might enter residential care, not because they're autistic, but because they're older, perhaps living with dementia, but also because we'd have very different needs and sensory needs in those environments. As I talked about the gender identity resource we've commissioned from GIRES, again, being worked on at the moment, hopefully here within the next 6 to 9 months. We're continuing the work on personal health budgets as one-offs, but this time for people on the list awaiting an assessment to see if that might help in some way. And I hope to be setting up soon. I had to pause things for the election, as you probably understand. Hope to be setting up soon a clinical reference group for those people who diagnose autism so that we can share better practice. We can think about whether things like pre-screening works or not, and if it does, how that might work. I'd be quite keen to look at peer pre-screening. Let people self-select by meeting their own potential new community. I certainly don't want to see those questionnaires like the one I had, where question 39 or whatever was, would you prefer to go to the theatre or a cinema or a museum? That's it. What's on? What? How on earth that was meant to be a measure of whether I was autistic or not, I have yet to understand. And also, we hope, it's currently sitting with governance, which again, as you probably know, takes forever, to be rolling out a neurodivergent-friendly employer pledge. I really wanted NHS England to walk the walk, not just talk the talk. And I'm pleased to say that in its production, we've had a lot of interest from the Royal College of Nursing, the GLA, the BMA, British Medical Association, and so on. So I really hope that perhaps councils like Enfield or even One-to-One might be willing to take that up as and when we're going to produce it. I'm sorry, you said something and I didn't catch it.
For me, I'm echoing on you. I say these not words.
Thank you very much. Nationally, we have some things going on. Annual health checks, which have been there for a while for people with learning disabilities, are being rolled out after pilots for those of us who are autistic without a learning disability. The reasonable adjustments flag is coming soon for our clinical records, so that anyone you visit in a health setting should immediately know that you have certain accommodations that you'd like to be made. And we're also working on a universal care plan where London has the pilot for that, although we are struggling to get partners to work with us, sadly. Again, with autistic people and those with learning disabilities, one of the pilot groups, or again, this would be a co-produced, co-designed support plan that you would have a lot of input to, that all medical professionals would have access to in any scenario you visited them. But I guess I wanted to finish. I'm trying to go a little bit quicker so we don't have to wait for lunch. I hope that's all right with you. Not with my words, but with an abridged version of someone else's. Again, just to show how the more we learn, the less we know, and how quickly things are changing, but still need to change. It was only in 1993, the received wisdom anyway, that the first autistic person was invited to an international conference on autism. Just one. His name was Jim Sinclair, and he wrote a piece and gave a speech called "Don't Mourn for Us." I think I'd like to finish with just a selection of what he said. Jim was particularly talking to parents of autistic kids, which might explain some of the language he uses. Autism isn't something a person has or a shell a person is trapped inside. There's no normal child hidden behind the autism. Autism is a way of being. It is pervasive. It colours every experience, sensation, perception, thought, emotion, and encounter, every aspect of existence. It's not possible to separate the autism from the person, and even if it were, the person you'd have left would not be the same one you'd started with. Autism is a way of being. So when parents say, "I wish my child did not have autism," what they're really saying is, "I wish the autistic child I do have did not exist, and a different, non-autistic child moved in behind their face." I find that hard to read even to this day. Read that again, because that's what we hear when people mourn over our existence. That's what we hear when people pray for a cure. This is what we know when you tell us your fondest hopes and dreams for us. Your greatest wish is that one day we will cease to be, and strangers you can love will move in behind our faces. We really need to change the language, don't we? It takes more work relating to a non-autistic person, sure, but it can be done, unless, of course, non-autistic people are far more limited than we are in their capacity to relate. After all, we spend our entire lives doing it. We're living in an alien world, learning to talk to you. Each of us who manages to function at all in your society is operating in that alien territory. We spend our entire lives doing this, and yet we are the ones told that we can't relate. So this is what I think, said Jim, autism societies should be about. Not mourning for what never was, but exploration of what is. We need neurotypicals. We need your help and understanding. Your world is not very open to us, and we won't make it without your strong support. Yes, there is tragedy that comes with autism, but not because of what we are, but because of the things that happen to us. Be sad about that if you want to be sad about that, about something. But then get mad about it and do something about it. The tragedy is not that we're here, but that your world has no place for us to be. I'm Andrew. I'm autistic. I'm proud to be autistic, but I only got there by speaking to other autistic people. I'm so pleased places like this exist, and thank you for having me today.